Okay, so then I'm going to get started. Okay, so starting at the top of the lower limb, we'll start with pelvic fractures in children. So the important things to know and consider when you're thinking about pelvic fractures in children is the mechanism, the associated injuries, complications, and considerations, classification, further imaging required, management, and then, of course, prognosis. So the mechanism of injury in children is invariably high energy trauma in the pelvis. So we know in the adult population, especially in the elderly population, fragility fractures, etc., can occur around the acetabulum and the pubic rami. But in children, this is highly unlikely, and 80 to 90% of injuries to the pelvis or pelvic fractures are caused by pedestrian vehicle and accidents, MBAs, and falls from heights. So differences between children and adults are that, of course, the bone is more elastic. So it actually requires a higher force to fracture the pelvis in a child than in an adult because of the ability of the bones and the mobile joints, the symphysis, the sacroiliac joint to absorb shock. Life-threatening hemorrhage is actually extremely rare, mostly in the setting of a pelvic fracture in a child and hypotension or other signs of hemorrhage. There you have to look really hard for associated injuries. Of course, you have to exclude the pelvis as a source, but it is far less common than in adults. They have excellent healing and remodeling ability, as we know, and then there's also more lateral compression types in children than in adults, and this is illustrated in this X-ray on the right. So associated injuries are extremely common, and this is kind of obvious if you think about the mechanism of injury leading to pelvic fractures in the first place. So 92, oh, there we go. So in this one study, there was a 92% incidence of associated head injuries, which is, if you think about this, it's virtually 100%. So also 56% incidence of other system injuries. So it's almost like a pelvic fracture is a marker of more severe injuries. I mean, by the time you have a pelvic fracture, there's a 60% chance of something else also sustaining a severe injury. And as you can see here on this study looking at pelvic fractures in children, the mean injury severity score was 31 in patients with pelvic fracture. So these, like I said, are markers of severe trauma, and one should be aware of that. Mortality associated with pelvic fractures are strictly associated with head injury and increased injury severity scores. So mortality associated with an isolated pelvic fracture is not really a concern in the pediatric population. So the classification we use, and when I say use, it's just the one that exists. It's not a particularly helpful classification. It doesn't guide your management to a certain degree, does prognosticate because it goes from not severe to more severe. But this is the classification for pediatric fractures, the Rode and Zig. And type 1 is an avulsion fracture, so it's illustrated in this image here. So avulsion of the muscles attaching to the pelvis. Typical in children, they tend to fracture and break through apophyses rather than rupture tendons. Type 2 is an isolated pelvic wing fracture. 3 is a segmental stable fracture. And type 4 would be a segmentally unstable fracture. You can also use the AO classification, which might give you more guidance as to what treatment is required, if any. So I have a few cases. We'll start with the seniors and then move along. So the first one on my list, unfortunately, is Bayanda.
Yes, I can hear you. Can you hear me?
How are you?
Well, thank you. Yourself?
Good. So let's have a look at this X-ray of this pelvis. And this is not a difficult question. I'm really just asking you to classify this injury according to the Rode and Zig and the AO classification systems.
The pelvic injury, Dr. Horn, not the head injury.
Did I say head?
Yes, you did. This is not a Red Cross trauma round. So this is, let me just look at it. So we've got the inferior, superior rami, trying to zoom in on the iliac wing and the SI joint on the left. I can't see it. There's that bowel overlying. So let's go to the other image. So it's bilateral. So it's a 3.
Yes. But which sacroiliac joint is disrupted?
Oh, there on that last on the outlet view. Sorry, I can see it now on the outlet view. So it's the left sacroiliac joint that seems to be disrupted there. So this is a vertically unstable fracture.
So it's an AO3 or a deriving Z type 4. But what I do want to point out is that on the inlet view here, there's a clear vertical translation or posterior translation of the right sacroiliac joint. So this one actually caught me out as well. So I was focusing on the left, and there does appear to be a crescent fracture. But if you look on the but on the outlet view, you can also see if you look at the sacral foramina and the location of the sacroiliac joint in comparison to the placement of the right sacroiliac joint. So this is very little bearing on your treatment. This patient was still managed conservatively. We usually keep them in the binder for a day or two.
Dr. Horn, you keep disappearing. I can't hear your sound.
Oh, I'm sorry. Sometimes this happens if I move my face away from the mic. But what I was saying is the SI joint injury is actually on the right.
Okay.
And so I'm certainly there with my arrow. But it doesn't really have a significant bearing on your treatment, as these fractures are still managed conservatively. Okay.
Okay.
So is further imaging required? Seldom. So at Redcross, our radiologists refuse to do special views because they reckon the radiation, once you've done inlet, outlet, and what are those oblique views that I haven't done for so long? By the time you've done that, you might as well have done a CT scan.
It's the obturator and internal oblique.
Yeah, but that have another name. Anyway, so we seldom do CT scans specifically to look. What, Ashley?
Two-day views.
Yes, thank you. Sorry, it was just eluding me. Yeah, so we seldom do special views in children. So because it doesn't really affect our management, we don't RF the pelvis. We seldom see acetabular fractures. But you can do a CT and a CT angio, especially in cases of hemorrhage where you're looking for a site of bleeding. And usually the CTs are done to exclude abdominal injuries, actually, and we just happen to be able to see the pelvis too. MRI is very seldom indicated. Sometimes in the presence of, for instance, a hip dislocation in a young child, there may be a cartilaginous disruption of the acetabular wall, and then we would do an MRI to visualize that, but that's very rare. So, case 2, Ben, I can see you on that. So just look at the X-ray and tell me what you think is going on there. Is there or isn't there a pelvic injury?
Hello, boss. Can you hear
Hi,
me?
Ben. Yes, I can.
I think there is. This is an AP view of a skeletally mature patient. I see slight, there's widening of the right sacroiliac joint.
Right.
Hello, I missed what you said, boss.
The right side.
Yes. I think that, and also I think the symphysis pubis may be slightly widened. I stand to be corrected on that note. So I think there may be a vertical shear component to this fracture.
Okay. Does anybody else want to comment on that? Do you agree with Ben?
Hi, Dr. Horn. So, Bayanda here, I see the widening of the symphysis pubis. There's also a catheter with contrast. So I think something probably happened there, probably an open book. So let me look at the back. I have to disagree. I think more the left than the right SI joint. And yes, I do agree it's a vertical shear, but it's coming from the left side. The left side is slightly up, not the right. I thought the right was fine, and the left is the hemipelvis that's translated proximally.
Yes. So, Bojana, I agree with you. And there's also a crescent fracture of the ilium. So the sacroiliac joint is probably intact, but there's a crescent fracture of the ilium there and vertical translation of the left hemipelvis. And the CT scan confirms this. So there you can see the intra-articular fracture of the sacroiliac joint on the left, the right side being completely fine. Okay, so what about the management of these fractures? So I put this X-ray up here to keep me humble. So this was an attempt at a pelvic Xfix at 4 in the morning for a very unstable fracture. Not my best work. And you can see this is clearly a very comminuted fracture, or quite a complex fracture there on the left. We did achieve some stability. The indication for the Xfix in this particular case, as you can see by the staples there, was that patient required a laparotomy. And hence they wanted us to stabilize the pelvis. But this looks terrible, I accept. So non-operative management is indicated in the vast majority of pelvic fractures in children, if there's less than 2 to 3 centimeters of displacement. External fixation is indicated for hemodynamic instability, increased pelvic volume, and of course associated procedures that precludes the use of a pelvic binder. And then ORIF, and this is according to the literature. So we've never done in my career ORIF of the pelvis. So yeah, but the books say that more to 2 to 3 centimeters of displacement, and then acetabular fractures are indications for ORIFs. The prognosis of pelvic fractures is mostly good. So patients remodel, children remodel, and there's also catch-up growth in the case of a vertically displaced fracture. Leg length discrepancy can be a problem, and this is typically in marked vertically displaced fractures. And then also, interestingly, iliac apophysis fractures or avulsions. So the reason for this is that the iliac apophysis is the growth plate of the pelvis. So that's where the ilium increases in height, which then obviously increases your leg lengths, and you can get a significant leg length discrepancy with an injury to apophysis at a young age. And there's also been some reports of late acetabular dysplasia in the presence of triradiate cartilage fractures. So Ashley, have a look at this X-ray and just tell me what you see.
Hi. So it's a low dox was completely immature child. What's most obvious is the left hip is dislocated. It possibly seems to be an anterior dislocation. Yeah, I feel it's an anterior dislocation, and there seems to be some bone fragments around the left hip. It's difficult to say where those fragments are from, whether from the acetabular wall or yeah, they don't seem to be from the femoral head. In terms of the pelvis itself, apart from the acetabulum, I don't think there's a pelvic ring. Well, on the left side, the SI joint seems to be slightly widened, compared to the right side. So, ultimately, I think yeah, that's all.
Yeah, okay, now I agree. It does appear wider. But just tell me, actually, where does the femoral head usually lie in an anterior dislocation? Over the bladder.
It's more. I was just saying that because to me the femoral head seems larger. The left femoral head seems larger than the right one. So I think it's likely anterior.
But just broaden your thoughts a little bit. So hips can dislocate posteriorly, anteriorly, and centrally.
Yes, yes.
Yeah. So this is actually central dislocation of the central inferior. So this the fracture through the acetabulum and the obturator foramen, and was sitting stuck there.
Okay.
Very unusual. Anyway, so we're talking about deep dislocations now. And interestingly, we actually just had an 8-year-old today at Red Cross with a posterior hip dislocation following a collision with a friend, which I suppose confirms what's written here. So it's rare injuries, but it's more common than proximal femur fractures. Low energy mechanism of injury in children younger than 10, and then the older than 10 group, it's usually a high energy injuries. It's posterior in 80% of cases, and associated acetabulum fractures are uncommon. And this is because, again, the acetabulum is partially cartilaginous up until 12 or 13 years of age, and therefore they can slip out without really fracturing the posterior wall. And there's a relatively high risk of AVN, 3 to 15%, especially if the reduction is delayed for more than 6 hours. And this is just an example of a child with a posterior hip dislocation, well reduced concentrically, no associated fractures. So following reduction, how long do we need to immobilize it? And we've altered our approach a little bit. I used to keep them down for about 10 days following the injury to allow the soft tissues to heal. But then we had some information from our adult colleagues, and I found out that you guys now mobilize patients day 1, 2 already post a posterior dislocation in adults, and therefore we've changed our strategy so they can go back to school sooner. So this is that same patient, Ashley, and here you can see.
Dr. Horn, sorry.
Yeah.
May I take it back? May I take it back? Sorry. So are we also doing the same thing? When you say day 1, must it be on proviso that they can straight leg raise, that we can mobilize them?
Yeah.
To get the
Yeah. So I mean, obviously, per ability, we're not going to force them up out of bed, but if they can, they can. No. So the straight leg raise is a good indicator. Okay, so this is just a CT scan of that patient that was illustrated in the low docs earlier. And here you can see the femoral head is actually incarcerated in the obturator foramen. I don't have enough views here to really see the sacroiliac joint on the right. I don't recall it being a problem, but we were so preoccupied with the hip. And then the bony fragment that was seen on the X-ray is actually the greater trochanter that was avulsed off with this central dislocation. So we managed to reduce it by putting a Steinman pin into the head and pulling it out, all closed reduction that things failed. And there it looks quite nice, concentrically reduced, and the greater trochanter is back where it should be. But X-rays demonstrated a intra-articular fragment which required a surgical dislocation for removal. Unfortunately, this patient did develop severe AVN, and he's currently being looked after by Maritz. Anyway, moving down. So now we've done hip dislocations, pelvis.
Sorry, Cindy. Can you hear me?
Yes.
Oh, sorry. I just wanted to ask for that child, any other injuries, just for interest's sake, with that bad hip injury? Did the child have anything else?
No, other than the pelvis and the pelvic ring. So you can see there's a pubic ramus fracture there, but no. So no intra-abdominal injuries, no others. It was actually just these implications.
Okay. Thanks.
So going back down now to the femur itself. So we divide it into proximal physeal fractures, or proximal femur, subtropic, diaphysial, and distal femur fractures, and we'll be going through all of them one by one. So who's next on my list? Like I said, I'm doing the pre-exam people first. Mohammed. So Mohammed, are you here?
Yes, boss. Hi. Yes, I can hear you. Can you hear me?
Yes, I can. So just look at this fracture, describe it, and classify it.
Okay, so this is an AP pelvis of skeletal mature patient. What I can see on the right side, there is an obvious fracture. It looks like a fracture through the physis of the right femur. What else? I can't see any other fracture looking at the pelvis itself. Maybe the right sacroiliac joint. Maybe it looks like maybe slightly widening. I'm not sure. And then also, if you look at the symphysis pubis, there might be a little bit of stip, so I'm not sure. But definitely there is a fracture through the fasciitis of the proximal. It's a transfascial fracture of the right proximal femur.
Classification system for proximal femur fractures in children?
Dalbert, yeah, Dalbert classification. This is a type 1. This is a type 1.
Very good. I must say, I didn't know this when I was a reg. You guys are very impressive. Okay, so proximal femur fractures in children. This is the Dalbert classification. I think the relevance of this classification is really the associated risk of avascular necrosis, which decreases as the classification progresses. So type 1 is the femoral head, as Mohammed said, with up to 100% risk of avascular necrosis. Type 2 is through the middle of the neck, 3 is basicervical, and 4 is intertrochanteric. And it actually makes sense that the further away the fracture moves from the growth plate and the precarious blood supply to the femoral head, the lower the risk of avascular necrosis in these patients. So the management, dose reduction and spica casting for minimally displaced fractures in the young child. And there appears to be an association with non-accidental injury in type 1 fractures in children under the age of 2. And then surgical treatment is very much tailored to the nature of this fracture. You can do open or closed reduction, smooth wires in younger children, of course, because you don't want to disrupt the growth plate, cannulated screws in older patients, and a DHS for type 4 fractures if the patient's older than 4. So remember, type 4 was the sort of per-troch or intertrochanteric fracture. So the AVN risk for the proximal femur fracture is directly related, of course, to the blood supply of the femoral head. And there's just a few interesting facts to know here, because it helps you to understand things like the risk of AVN in SUFI, Perthes disease, etc. So the femoral head in a child is solely dependent on the medial femoral circumflex artery from the age of 4 onwards, until basically skeletal maturity. So remember, in adults, there's no physis. So metaphyseal blood vessels cross into the head of the femur, and therefore you can treat displaced femoral head fractures in young patients with closed reduction, open reduction, and pinning, because there is transfascial blood vessels. So the lateral femoral circumflex artery and the artery of the ligamentum teres initially contributes to the blood flow, or to blood supply of the femoral head, but it basically regresses and disappears completely by the age of 3 to 4 years. And this renders the femoral head extremely vulnerable, as it has a single end artery supplying it with blood. And then the metaphyseal vessels, like I said, up to the age of 3, they do cross the physis, and then they re-anastomose once the physis closed at skeletal maturity again. So that age between 3, 4 to skeletal maturity, there's one artery supplying the femoral head, and that renders it, of course, very vulnerable. So this isn't really a very difficult one. So who's next? Who else? Oh, Dalroy. Okay, he's not here. So now I'm just going from the top. Omar? Abbas, are you here?
Yes, Andrea, I can hear you.
So just tell me, don't worry about the left side of femur fracture. Just look at the right, classify it, and tell me how you would treat it.
So proximal third femur fracture on the right side. That's displaced into varus. Looks like it's not going through the physis, but I'm worried about the GT if it's involved as well, the greater tuberosity physis. I'll still classify using the Dalbert classification. Hello? Yeah.
Which one is this?
The Delbet classification.
Yes.
Yes. If I remember correctly, that should be type 3
No.
or type 4.
Okay. You keep guessing, you'll get there eventually. Eh? So it's type 4.
Yeah, type 4. Yeah.
And the avian risk?
Sorry.
What is the risk of avascular necrosis in this patient?
So the risk is not as high. It's about 40% or so.
It's 5%.
It's 5%. Okay.
Yeah.
Okay.
And treatment? So she's 6 years old.
Treatment, open reduction and internal fixation, and this case angle blade fixation or DHS.
Yes, well done. Okay,
Yeah.
good. Thank you.
Thank you.
And Selma, you're next. So,
all right. Good evening. So I'm also seeing here X-rays of a skeletal immature patient. Obvious fracture here is what looks like a subtropic femur fracture. Doesn't necessarily fall under the Delbet classification, as it's, but yeah, it falls under proximal femur fractures. Let me see. I'm not appreciating any other fractures except for that. And I would like this 8-year-old male. So would have to treat this with open reduction internal fixation. We can do tense nails for this patient, or a pediatric femur nail for this patient. This management.
So, for an 8-year-old.
That's why I mentioned the tense nails initially, using the anterograde approach. But other than the other options are plate in this area as well.
So no, that's good. So that's basically just what I wanted you to get at, is that there's no role for conservative treatment in this patient.
Yeah.
So you can see it's quite displaced. He's very flexed if you look at the lateral, and he's quite abducted if you look at the AP. Yeah. And there's no way that you're going to get a satisfying outcome or satisfactory outcome in an 8-year-old child with this fracture. So fixation is the key. And then talking about the different ways, yes, TENS or plates is a little bit young for a nail. Yeah. So we sort of say from 9 onwards, we know it's okay, but you're pushing it a little bit in an 8-year-old. Okay, so there's no specific classification for subtropic fractures, but we know that they're more prone to displacement and not amenable to conservative treatment. And that is because of the flexion and shortening secondary to the psoas, abduction due to your overpowering hip abductors, and external rotation due to your hip external rotators inserting into the proximal fragment. They're also less likely to remodel because, as we know, the closer you are to the growth plate, the more you remodel, but they are close to the proximal femur growth plate, which doesn't contribute massively to the length of the femur. And furthermore, because they tend to deform into varus, they are deforming stresses over the fracture during normal weight bearing, which further leads to a lack of remodeling. This is just an example of such a patient that was treated conservatively, and this was his final outcome. And he actually ended up requiring a corrective osteotomy to correct that proximal femur varus. So go for it first. So now the question, and this comes back to what Salma was saying, is what do we do for them? Oro for TENS. And there has been some comparative studies looking at open reduction and plating versus TENS for proximal femur fractures. So the TENS tends to have a shorter operative time, less blood loss, but more complications. A plate is more appropriate for these, but both are safe and effective. In my opinion, the plate is a simpler procedure for this. It's a very difficult TENS. versus a very easy plate. So that's just where I go, but both of them are appropriate. And it depends, I suppose, on your skill set and what you like to do. So you'd probably have to use an anti-grade pens here that we're not that familiar with. So just plate it, and then the patient can go home. Look at that. 6 weeks later. Okay. Then diaphysial fractures. There's not an awful lot to say here, but we'll talk about what there is to say. So this is quite a seminal article that was written by Prof. Hoffman back in the day, because he's old now, he's 30 years old. And this is quoted in not Campbell's, Rockwood, in Rockwood's Fractures book. So they looked at the at remodeling of femur fractures in children. And their conclusion was that in children under the age of 13, you can accept 25% or 25-degree deformity in any plane. Obviously not rotation, we know that, but coronal or sagittal. And they also found that the 3/4 of the remodeling occurred at the physis. And what that means is that the body tried to realign the joints without making too much of an effort to straighten the bone in between. So you would have a corrected mechanical axis, but you might still have a diaphysial deformity because the diaphysis doesn't actually remodel that well. But this is an old article. And as with everything else, people have become less tolerant of deformity, shortening, and any form of disability. And I think we as surgeons have also become less tolerant of ugly X-rays. So there's this excellent article. It's like 5 years old now, but nothing much has changed. Just take a little screenshot here so you can go read it. It's very good. So it's the management of pediatric diaphysial femoral fractures, a modern approach. And they have this table or this algorithm here, which basically sums it up. So for your, obviously there's always the caveat, so guided by socioeconomic considerations and surgical experience, and polytraumas are slightly different, pathological fractures are slightly different. They're talking about isolated femur fractures. For the proximal ones, the internal or external fixation. So we've spoken about that. Diaphysial shaft fractures, less than 6 months, fabric harness or a little bit of traction. 6 months to 5 years. So we tend to, no, we're actually quite on par with this. So skin traction and a spica or just a spica, 5 to 12. Now we're starting to operate. So 10s, consider plating or Xfix for comminuted or length unstable fractures. Rare indications for non-surgical treatment. And in the last 5 or so years that I've been working at Red Cross, we have a lot fewer patients being treated definitively in skin traction than before as well. So we used to have like 2 rows of skin tractions at Macon Cottage, and now we have like 3 or 4 patients. So we are definitely moving towards more surgical intervention for these fractures. And then yeah.
Anria, sorry. And gallows? Is that gone now?
No. So gallows is obviously, it is an old way of treating femur fractures. It works extremely well. They talk about skin traction. Gallows is nothing else than skin traction.
Okay, all right. So it's not just because they don't call it by name, it doesn't exclude it.
Yeah, exactly. Gallows is just portable skin traction, essentially.
All right, okay. Yeah. Thanks.
So then for the older than 12 years, so they are a little bit more conservative here in terms of who can get an intramedullary nail. We are, like I said, from 9 onwards, I feel it's safe. The literature supports it, we'll get there now. But for children older than 12, less than 50, they get a 10 with or without, or a plate, depending on the combination and the pattern of the fracture. And if they're more than 50 kilograms, they get a nail, basically. So that's a summary, and if you know that, then that's going to guide your treatment for the rest of your career. I think it's a very good algorithm. Then we just look at a little bit of detail. So, you know, we do a lot of spikers at Red Cross. So here was a systematic review was done of spiker treatment for children, and in terms of specifically what degree of deformity was tolerated. And this is, it's a funny study because it doesn't look actually at what works or what the patient can tolerate or what remodels, but more what the cutoff was for surgeons across the world where they said, no, this is unacceptable alignment. And the accepted femoral shortening I don't know who treats 16-year-olds in spikas, but anyway, here we go. So up to 2 centimeters was accepted up until about the age of 6, and then less and less to the point where only about 1 centimeter was accepted in the older patient. Okay, so that's not really great news there. Oh, just to go back to that slide, you have to be careful of the overgrowth phenomenon. So we know that children can catch up, and it's mostly due to hyperemia of the broken bone stimulating the growth plates. And most of the catch-up growth occurs in the first 18 months after the fracture. So if you still have a leg length discrepancy after 18 months, that's not going to get better by itself. But you can overshoot your target, so end up with the fractured limb being longer than the other one because of the overgrowth phenomenon. Sagittal plane angulation. So what was tolerated here? You can see in the frontal plane, we're nowhere near 25 degrees here. So on average 15 degrees, 16 or so. There's a few outliers going down to around about 8 by the time you've reached skeletal maturity. Same for the sagittal plane angulation, starting at about 20 degrees for the very little ones and going down to just over 10 of what we can accept in a femur. So I do think that 25 degrees is maybe a little bit too much. And we're definitely more aggressive in obtaining alignment these days. Then there's a little questions about double leg versus single leg. You may read about this when you do your reading. There was one comparative study done, and the single leg spica cast had a marginally higher rate of malunion. But frankly, by the time I'm putting a spica on a child, I'm not really concerned about malunion because you can't really control the femur very nicely in the spica. So that's not really important. There's a slightly higher rate of cast failure, but there's better casting tolerance and less caregiver burden. So if you go out on your own one day and you're doing spikas for children, a single leg spica is probably an attractive option. So what do we do for children between 5 and 12? These are our options, like we said. So spikas, not so much plating, things, iron nails, traction. That's your armamentarium. So let's talk about TENS a little bit. So now we know, we say TENS are indicated for patients under the age of 49, not under the age, under the weight of 49 kilograms. So 50 and above, you can't TENS it. But now you have a 5-year-old that weighs 8 kilograms, like this up. Now what do you do? So there are some controversies regarding intramedullary nails, but not terribly many. So what's the maximum weight tolerable? Do you use just 1 or 2? And then titanium versus stainless steel. Just reminding you of Young's modulus, so we know that stainless steel is more rigid than titanium, or less flexible. So moving along here. So now this was a study done on children over the weight of 50 kilograms with TENS, looking at complications, and this is 110 pounds or more, so that's about 50 kgs. So they had 4 out of 20 complications at 20%, so that's not really very good. 2 malunions, 2 non-unions. But this group used titanium nails. In this study, which was from somewhere in the States, they also did flexible intramedullary nails, but they used stainless steel. And their patient, the heaviest patient, was 80 kilograms. And they could not illustrate the statistically increased risk of malunion or delayed union, but they use stainless steel nails. So if you're going to consider doing a fascial sparing technique like a TENS in a heavier child, then opt for stainless steel nails, if you can get them. Then, this is just for the sake of interest, there was a study looking at a single nail, and they did fairly well. Only 3 patients had a little bit of shortening. So if you're on a tight budget, you can just use 1 nail as well. That works. But now, what about intramedullary nailing? So I think that's probably the thing we worry about most, is what age is appropriate, what are the risks, etc. So one of the problems is that the nails are too big. So for a small medullary canal, there's a risk of AVN. Is there? I don't know. Risk of growth disturbance, certainly. But is the major problem maybe certain reluctance, because we're just not used to doing it. So just reminding us again of the proximal femoral anatomy. The first problem is blood supply to the femoral head. There's your medial circumflex inferior artery. And then the second problem is growth arrest from the greater trochanter. So piriformis nails have been largely abandoned because of the high rate of avascular necrosis. So we don't use that anymore. So it's a moot point. And the lateral trochanteric nail does have a risk of growth alteration, but it has been proven to not really be clinically significant. So this is another excellent study. There's a very large cohort and a 20-year follow-up for an intramedullary nailing. So the age ranges from 8 to 17 and quite a long follow-up as well. 246 fractures. So this is a good study. No AVN. Yeah, so we can scratch that. Don't care about that. 2 patients had radiologically relevant growth disturbance, but both were asymptomatic. They found some minor differences in the articulotrochanteric distance, asymptomatic, and their complications were related to the implant, so screw migration and some sepsis. So this would basically suggest to you that 8 years and older, lateral intrafemoral nails are safe to use. And the nice thing about that is that we're very familiar with the technique. So nails not small enough, that has basically been addressed by the pediatric nails. I think the smallest diameter is 7. So it's seldom that you'd want to nail somebody that you can't get one in. Risk of AVN, not a problem. Growth disturbance, not a problem. So 8 to 9 years older, we nailed them. Okay. Then, for those guys that were at Reg Congress, remember one of the debates was about submuscular plating versus TENS for pediatric femur fractures. So it is a accepted technique. I must say at our unit, we don't really do it. Tigerberg's very fond of submuscular plating. It just works for them. They want to mobilize the kids and get them out of the ward and get them home. So, and they're also quite skilled at it. So that's very good. So this study just looked at the long-term results. There are a few superficial infections, don't really care about that. 5 leg length discrepancies and 5 varus and valgus malunions, and their fluoroscopy time was 55 minutes. That's quite a lot. Then this was a good study looking at comparing things to submuscular plating. It's a relatively small cohort, 28 and 30 in the respective groups, but the blood loss was more with submuscular plating. The operative time was almost double with the submuscular plating. And then when they take out the implant, again, the blood loss and the operative time was almost double. So in our type of environment where theatre time is at a premium, I think you go for what's fastest, especially if both techniques have been proven to be effective. So we will stick to the TENS for now. Of course, if there's a length unstable fracture, you'll do something else. But for a simple fracture, this is the answer. Okay, so we're just going back to that. So it seems that our practice does align with this algorithm. And like I said again, take a screenshot. This will do you good. Okay, so next up on my list is Cindy. So this is a slightly more complex patient. So this 8-year-old male, MBA with an open deep fracture. So don't worry about classification or describing the fracture or anything. What would you do for him? Isolated injury.
Sorry, I just missed it. You said it's closed?
Open.
Open. Okay, 8-year-old male with an isolated left open femur fracture. First of all, this is a low dox. Before I get to the management, I would just like that splint away so I can see if there's a distal fracture as well, because that would obviously also influence the management. This is an open fracture. Also, depending on the patient's stability, I have to consider, am I going to do damage control surgery? How big is the wound? Am I going to do an Xfix? Or is this amenable to a plate? It looks a little bit spiral, so it's length unstable, so necessarily not doing a TENS here. But depending on the wound, like I said, in the patient's status, an Xfix can be considered, alternatively doing a plate.
So the surgeon on call that night opted for an Xfix. So you can see what happened here. So what's the problem now?
So initially looked well reduced with the Xfix, and it has healed on the one side. there's a bit of a bowing, bit of a varus deformity, and the lateral side, you can see, I don't know, it doesn't look completely healed. There's a, yeah, I'm not sure I'm using the right words. Yeah.
You're right, but that's not really the point. The point is there's a varus malunion. So a unilateral Xfix for a diaphysial femur fracture is actually just not great. So we just had today at Maitland, we saw another child 7 weeks post-injury, lots of callus on the x-ray. So we dynamized the Xfix, and after 2 days of walking, he's now also gone into procavatum and varus. So I just don't think the stability, and especially in the presence of an open fracture where you have loss of your hematoma, this is not, for me, a very nice solution for a femur fracture. So maybe as a temporary means while the patient is unstable and while you're concerned about the wound, but then to convert to something else, so intramedullary or plating. Okay, but then we accepted the slight varus malunion, but now he comes back to our clinic with this situation. So what do you think's going on there now? Let's look at.
Okay, so yes, we have the obvious varus mal or deformity noted in the femoral aspect. There's also probably some shortening. I can't, although the pelvis doesn't look as tilted. Yeah, there's a definite. But I wonder if you align the mechanical axis. Oh no, it's still going to be out. The femur is in varus and the tibia is in more valgus.
Yes, why?
Because of your center of rotation.
What?
No, I'm going to
Can I cut in, Dr. Horn?
Yes, go for it.
I'd like to see the previous one, but I think there probably could have been a missed Salter-Harris 5 of the distal femur. Because if you look at the distal femoral condyles, there seems to be the lateral condyle is not as big as the medial one. So I think what happened was there was a physeal injury that was missed in the distal femur. So there's actually two angular deformities in that femur. It's mid-shaft and distal femur.
Absolutely. So, Cindy, you were right to say on this stage that you wanted to see if there's a distal fracture. There was none visible, but that's the problem with Salter-Harris 5s, is you can't see them, but you can see quite significant swelling around this knee. We obviously just described it to the diaphysial fracture. Yes, so now this child has a new onset deformity due to a missed Salter-Harris 5 fracture on the left. Okay, so this is now a complex deformity, and this treatment is also quite complex. But we're not really going to go on to that now. But you can see the physis is irregular, and that's due to the physeal bar having formed laterally there. That brings us to distal femur fractures. So most commonly, Salter-Harris 2, same as with any other bone, and the growth arrest related to femur fractures is related to the Salter-Harris type and the degree of displacement. Surgery does not influence the outcome of growth arrest. So your operation cannot stop it from happening. Yeah, so this article looked at predicting the outcome of physeal fractures of the distal femur, and they correlated the risk of complications. So this is mostly growth arrest to the various Salter-Harris grades. And as you can see, as your Salter-Harris grade increases, so does your risk of growth arrest. So they're only at 1.5, it's like 100%. It's not really statistically significant, but this does indicate the increased risk. And we know that. We know 4 and 5 tends to be associated. Furthermore, the distal femoral growth plate is undulating in nature, which means that unlike, for instance, the distal radius, if you have a Salter-Harris fracture, it's quite smooth and it just goes out and back in again. But because of the shape of the distal femoral physis, it's just more prone to injury with Salter-Harris fractures. And this is interesting. So the degree of displacement in, well, percentages, so a third, 2/3, more than 2/3, was also directly proportional to the rate of growth arrest. But I suppose that also makes sense because for a more displaced fracture, you obviously have a higher force or greater force of injury. Okay, then, so the treatment of physial bars in distal femur fractures is also a little bit controversial. So the physial bar excision is indicated or considered if there's less than 50% of the surface area of the physis involved in the bar. This you determine by doing MRI so that you can map out the size of the bar, and then using the metaphysical window, you sort of dig down to the physis, find the bar, burr it out, put in cranioblast or bone wax, but mostly we prefer cranioblast. And then the idea is that it's not that that part isn't going to grow, but it's not going to tether the bone, because that's how a bony bar works. It stops the active growth plate from growing by forming a tether, essentially. And these people had a very good results. They were quite happy. However, almost a quarter or more of their patients required revision bar excision. And then they also needed several other procedures like deformity correction, lengthening, epiphysiodesis, etc. And this is just one of the little x-rays. So you can see I had a physial bar there in the ankle, and they burred it out and in cranioplasty. And you can here see that, yes, there's a leg length discrepancy, but symmetrical growth has been restored. Personally, I don't have any experience in this. I know Stuart has done quite a few of these, but we tend to do them very infrequently at Maitland. I think if you have a young patient, you should try, because they obviously have a lot to lose in terms of length if you ablate the growth plate completely. So in children under 8, I would probably be more likely to try a physical bar excision, but in the older patients, it might just be simpler and more reliable to correct the deformity, complete the epiphysiodesis, and do a contralateral epiphysiodesis. Okay, patella fractures, you've got one slide here. It's very interesting. It's the same as in adults. It's not very common. The only thing that's different is the sleeve avulsion fractures, and those ones we fix with bone sutures or suture anchors. And that's all I have to say about patella fractures. Okay, next case is going to Francis.
Hi. All right. So we've got a lateral and 2 APs, or AP of both sides, of a proximal tibia in the knee, with avulsion of the tibial spine. On the lateral, so the AP, you can't really judge the displacement well, but on the lateral, it's completely loose and angulated. It doesn't look like there's a posterior tether. So it's a grade 3. If I recall, I might get the name of the classification wrong, but I think it's something like a Bado. No. No.
Myers-McKeever.
Myers-McKeever, that's the one. Okay.
Yeah, but you're right, it's a type 3. So which associated injuries would you be concerned about in a type 3 Myers-McKeever fracture?
So I'll be concerned about other ligamentous injuries around the knee. Probably much like an adult, also your MCL and your possible meniscal injuries. Probably more the anterior horn of the meniscus.
And how would you exclude those?
So clinical examination first. Will need to be in a sedated patient or in your EA when you take the patient to theatre. You can confirm with imaging, such as MRI, or otherwise with arthroscopy.
And then how would you treat this particular fracture?
So the grade 3, you can't really reduce, close and keep it. So you need to take the patient to surgery, and you can do arthroscopic or open reduction. You need to basically get it down. You can use a ACL tunnel with a screw, or also like a suture tendon, and then you need to join it to the tibial tuberosity on the outside.
Yeah. Okay. So that's the basic principle. So you can't treat grade 3s Conservatively, there's a high risk of associated injuries, and the treatment is surgical, open or arthroscopic, screws or suture. So now, of course, they say which one's best, which one are you going to do? So just a little bit of background, we know the ages 8 to 14 is usually indirect trauma, same as the ACL rupture. It's basically pediatric ACL ruptures. Associated injuries, meniscal tears or entrapment is the most common. Collateral ligament injury, far less common, but possible. Capsular injuries, and then osteochondral fractures. Depending on the severity of the injury, we use the Myers-Brugger classification. Excuse me, so type 1, 2, 3, and then 4 was a comminuted one, which was added later on by this person whose name I can't pronounce. Okay, so what is the incidence of meniscal entrapment and injuries or associated knee injuries? So higher than you would think. So on MRI, a third of patients have meniscal tears, lateral more than medial, but that sort of goes with the mechanism of injury of ACL rupture, which is more like an external rotation force. Osteochondral injury, quite significant, almost 70%. Non-ACL ligament injuries, 32%, and then intermeniscal ligament entrapment, 4%. This was seen on the MRI. Then the same patient cohort was taken to theatre, which slightly altered the number of injuries. So they found slightly more injuries for the meniscus and the intermeniscal ligaments, but less ACLs and less chondral injuries. So what these authors recommend, and that's kind of what we've adopted, is to do an MRI for grade 2 and 3s upwards to see these injuries and decide whether or not they warrant surgery, because that's going to obviously determine whether you're going to do it open or arthroscopically. So the management, so the associated injuries you treat on merit. Most meniscal injuries will actually heal in young children. OCDs you treat if unstable, and it's seldom necessary to fix the collaterals. And the fracture, well, there's, like I said, there's controversy or some argument between open versus arthroscopic and suture versus screw versus ACL reconstruction, which is actually also an option. So this paper looked at the difference between arthroscopic and open reductions, and they found that there was a significantly higher incidence of arthroplasty in the arthroscopic group. But when they did the multivariate analysis, they found that the arthroplasty wasn't directly linked to the arthroscopy. It was linked to the length of surgery. So the arthroscopy took a lot longer. You can see there's an hour and a half for the RF and then 2 hours for the arthroscopy. And because only certain surgeons had the skills to do it arthroscopically, often the surgery was delayed until the surgeon was available to do the arthroscopic repair. So it very much depends on your skill set. If you can do a good scope and you can fix it arthroscopically, go for it. It's obviously a smaller incision, patients mobilize a little bit easier. But if you're like me and you don't know anything about arthroscopy anymore, then you can do it open. The limitation of that is, of course, that you can't address associated injuries. So if there is a meniscal injury, you can't do anything about that. And then screw versus suture. So there's no conclusive difference in the outcomes between the two if you exclude all the other variables such as surgical technique, grade, and that kind of thing. They found slightly more laxity and prominent hardware in the screw group, and that's because with the ACL, with the avulsion of the tibial spine, there is stretching of the ACL. So even if you get an anatomic reduction of the tibial spine, there will still be some laxity in the ACL because it was stretched, but this is seldom clinically significant. Then they also found slightly more arthroplasty in the suture group, and again, it's probably because it's a more fiddly operation, it takes longer, and hence. So your screws can be extraphysial, so you can see if you put them in obliquely and so on, you can miss the physis completely, whereas the sutures tend to be transphysial and can sometimes lead to growth inhibition. Anyway, so that is something that's quite unique, and there's a little bit of controversy about it, but if it's just you and you need to fix this thing, just open it. It's actually a very simple open procedure. You can see that the tibial eminence quite nicely. Get your cannulated screws in there, and it's very satisfying, and they do extremely well, even though there is a slightly bigger incision than with your scope. Then the tibial tuberosity fractures, we're moving down. Uncommon injury, typically adolescent males. It's a sporting injury. It's an avulsion of the tibial tuberosity. Management, if it's not displaced, then operate. If it's displaced, operate. And if it's a grade 3, if you look at this is the Beta classification. The ones that extend into the joint, so the grade 3, they recommend arthroscopy so that you can look for associated meniscal injuries. And the complications is recurvatum, ligament discrepancy, and possibly compartments. That's all I have to say about that. Okay, who's next? Who's HP? There's somebody on my list called HP. I don't know who that is. Yeah, leave him alone. Or her, don't you know. Okay, then after that, Johan, is this Johan Groenewald?
Hello, Andrea. Yeah, Johan.
Hi, Felice. So look at this fracture and then just tell me what you are concerned about and why in a 4-year-old.
Okay. Andrea, I can see tib fib fracture, tib fib X-ray, AP views, and I am concerned about valgus deformity. You can see especially around the proximal tibia. So I think this patient probably had a proximal tibial metaphyseal fracture, now has a valgus deformity.
What's that called?
It is called, let me just go to my folders. It's the Cozen phenomenon.
Yes, well done. And what causes the Cozen phenomenon? Is it a malunion?
If I remember correctly, around a cup of coffee, we used to say that the etiology is unknown, but they think that there might be vascular reasons. And then also, if I remember correctly, there's a malunion as well, vascular regions, but grossly, we don't really know what the etiology of that is. But if you look at the fracture characteristics, usually follows poor reduction. There might be infolding of the periosteum. And they also talk about, if I remember, the pes anserine insertion can also be involved in the fracture. That also basically leads to soft tissue interposition that can also lead to this. But it doesn't matter what type of treatment you do for these type injuries. It doesn't matter if you do a close reduction or surgery, it can always develop late as a consequence of that. And it's very common in these proximal tibial fractures.
So this is just a unique little idiosyncratic pediatric thing. Is they get undisplaced proximal tibial metaphyseal fractures. You put them in a cast, they don't malunite, they develop valgus. This is the same patient, and you can see his valgus actually got a lot worse over time. So it happens typically in 3 to 6 year olds. We don't know. The clinic is right. We don't know for sure. So we think it might be vascular. So because the tibia isn't fractured, the fibula is fractured. There's relative overgrowth of the tibia compared to the fibula. That's one thing. Malunion to a certain degree because varus molding of the fracture, basically over-reducing it in varus, can obviate this complication. And then also, like I said, asymmetrical physeal growth. So once it occurred, you can observe them for up to 2 years. If they haven't spontaneously remodeled, okay, I'd rather go for 18 months. 2 years becomes a bit long for me. But if there hasn't been any spontaneous remodeling by 18 months, then guided growth is a simple solution. But this is something to warn parents about. So don't just discharge these patients once they're united. Warn the parents that this can happen, that should bring them back or organize a formal follow-up for them. Okay, I think this is like my only, oh no. Okay, so this is diaphysial tibial fractures, not terribly different from adults. We accept a little bit more malalignment. So 5 to 10% angulation, 5 degrees rotation, and the remodeling potential is obviously also indirectly proportional to the age, where almost 100% of deformities will remodel in the under 8 group and very few over 12. And this is just an interesting little study comparing closed treatment with TENS. And I must say, I like doing TENS. It's very tidy. It's sort of, you know, instead of watching that sort of malaligned fracture and fracture clinic for 6 weeks and trying to convince yourself that it's going to be okay. But if you look at the complication rates, so between major and minor, there's 9% complications in the cast group and 24% in the TENS group. So that is a little bit off-putting. So for me, I would say the indication for surgery would be open fractures, of course, but then you wouldn't necessarily TENS them. Inability to obtain a stable reduction, which can happen with these mid-shaft tip foot fractures that are just incredibly unstable. If there's a floating knee, and then if there's some associated injury that forces your hand, you can't use them in the cast. So relatively low threshold or high threshold, sorry, for surgery in tibias. Okay, guys, we're nearing the end. We're at the ankle now. So ankle fractures in children. Kim, what's the classification system for ankle fractures in children?
Hi, Dr. Horn. It depends. So you can classify it in terms of the pattern or the Salter-Harris. We know that the growth plates, and obviously the age of the patient is very important because of the way that the physis closes. So there are some specific names for specific fracture types, like the Tolo or the triplanar fracture. So I think I'd first assess the patient's age, look at the fracture pattern, decide if Salter-Harris is more appropriate or...
Let me just stop you.
Sorry.
There's a classification system that's based on the Laug-Hansen classification of ankle fractures in adults that we use for kids. Do you know it?
I can't recall it at the moment, no, sorry.
Any other takers?
Diaz and Tajian.
Tajian. Well done. Yes. So that is sort of the pediatric version of the Laug-Hansen classification. It's also mechanistic. And so, yeah, basically, I think it's useful in terms of understanding the force that created the fracture so that you can understand the force required to reduce the fracture. That for me is the value of this classification, but I wouldn't go as far as to say I know it by heart. It's in the books. So Diaz and Tajian, and you've got your supination inversion fracture, and this is your typical ankle sprain. Is it a lateral malleolus fracture? Is it an ankle ligament fracture? Is it undisplaced? This is the most common form of ankle injury in a child. And it's only if it's a more progressive injury that they will knock off the medial malleolus. Yeah. Then there's the supination plantar flexion one. This is fairly common, and I think this usually happens when children trip. So the foot gets stuck somewhere, they plantar flex as they fall over it, and they knock off the back, the posterior malleolus there. So that was fairly common. This one far less common is extraphysial actually. So it's a metaphysial fracture, supination, external rotation, and then pronation eversion. This is also a relatively common one. You can see you knock off the lateral part of the metaphysis there, and there's a transverse fibular fracture. So that's the classification we use, and like I said, useful to understand what you have to do to reduce the ankle. So one of the big questions we ask ourselves is, if a patient comes with a typical supination injury, x-rays are normal, is this a lateral ligament injury or is it a Salter-Harris one of the distal fibula? So I was taught, and I've been teaching until recently, that it's definitely a Salter-Harris one of the distal fibula. And then I found this article, which made me change my mind. So they looked at 135 patients with normal x-rays and lateral malleolar pain and swelling. Of those 105 patients, only 4 had a physial injury. The rest were all ligament injuries, including associated fibular avulsions. So the prevailing knowledge of it being a Salter-Harris 1 fracture is incorrect. It is probably a lateral ankle ligament fracture. Does it affect on management? Not really. So you would still treat the majority of these injuries conservatively. There is definitely room for fixing the avulsion fractures, especially if there's significant instability or if it's quite athletic patient. So here we just go for the management of ankle fractures, open or close reduction and fixation, K-wires versus kinematic screws. And this paper looked at whether or not surgical management reduces the risk of premature physical closure, and it actually doesn't. So they could find no difference between the surgical and non-surgical group. So it's similar to the distal femurs. Your management doesn't really affect the prognosis in terms of growth arrest. The initial severity correlates with the growth arrest, and this study actually recommend conservative management. Having said that, if there is clear periosteal interposition in the soft fracture gap, so if there's a more than 3 millimeter gap in the physis and you can't reduce it close, there's probably periosteum, and I would probably still recommend that you go and take it out and get an anatomical reduction. And then, of course, if there's an intra-articular fracture, you need a meticulous anatomical reduction again. Okay, so Kim, having now gone through the classification, and okay, this is actually no, forget that. Just tell me what this is. So looking at the AP and the lateral, and this is a 12-year-old patient.
My first thought is it's got both, it's a complex injury, looks like possible triplanar involving portion going through the physis. So there's quite a significant large, I'm not sure if you'd call that the Thurston-Holland fragment posteriorly, if that needs to be reduced. And this I would definitely manage with surgical intervention, or unless you can get a very good reduction with a good, well-molded blaster. But I would watch it very carefully.
So in a triplanar fracture, Kim, which planes, so just you can describe it to me. So we talk about 3 planes. So sorry, I'm actually pointing at my screen as if you can see me. Anyway,
so on the AP,
yes.
On the AP, you see that the fracture line exits through the epiphysis quite clearly. So that would obviously be your 3, and then on the lateral, you're seeing it exiting through the metaphyseal or the Thurston-Holland fragment. So that would be your 2. So it would be the combination, and then together, I think they call it a 4 because it goes across the so your central part is the first part of the physis to unite. So that's the part that remains intact.
So we've got to go over the pathoanatomy again quickly.
Okay.
So triplane fractures, the 3 planes we're talking about is the sagittal plane, which is the one that you can see on the AP, and that's a physial fracture. Then in the coronal plane, that's the one you can see in the metaphysis, and that's that one there with the Thurston-Holland fracture. So that fractures in the coronal plane, and then the transverse plane, which is the one that's going through the physis. So those are the 3 planes, and this diagram here illustrates it quite nicely. And as you correctly said, the pathology behind this fracture is the sequence of ossification or fusion of the growth plate of the ankle. So it starts in the middle, and then medially, and then finally anterolaterally. Excuse me, and that explains the mechanism. So for instance, so this is a triplane fracture, but this is a tillo fracture. So a tillo fracture, if you look there, is basically an avulsion of the anterolateral last little piece of unfused epiphysis of the ankle. And I suppose the adult, what can I say, the similar adult type of injury would have been a syndesmosis disruption. Okay, so triplane occur in patients that's younger than tillo fractures, because if you look at the pathoanatomy again, you'll develop a triplane fracture if you have this situation, or this one. So you fracture through there, and this is a tillo. So it just sort of, it's sequential prop. Preoperative CT is usually indicated to define the fracture well and plan your surgery. So more than 2 millimeters of displacement warrants, or if same as with adults. Postoperative CT, I don't know. I think if you could see what you were doing quite nicely in theatre, it's probably not necessary, but Why not? You might as well. Growth arrest is rare. Why? Can you hazard a guess, Kim? I'm still busy with you.
I suppose it's an area high vascular. I think it's because it's not going to make too much of a difference in the long run anyway, because they're already fusing.
So growth arrest is not a concern because these patients' growth plates are fusing anyway. So even despite the fact that it's sort of like high risk, salt high risk for injury, growth arrest is just not an issue. Even if it does fuse, so what? It would have fused anyway. Yeah, so good. So we're more concerned about anatomic reduction to prevent intra-articular problems like arthritis in future, but we don't care about the growth plates anymore. And then lastly, just because I had to do something for the foot, pediatric Lisfranc injuries is very rare in the developed world, not so much here because of the car drove over foot phenomenon that we see so frequently. It's also frequently missed because the bones are incompletely ossified and you can't necessarily appreciate the widening of the joint space. So clinical suspicion needs to be based on the mechanism of injury, severe swelling out of proportion to what you can see on the X-ray, and plantar ecchymosis. We all know this. X-rays will show you 2 to 3 millimeter gap between the first and the second metatarsal, and it becomes extremely difficult to interpret this in younger children that are so poorly ossified. So there's no clear guidelines, and again, clinical suspicion would be the way to go. I wouldn't recommend further imaging in a very young child because we treat them conservatively, almost invariably. So if it looks like a slight widening, then you can accept it as a Lisfranc and treat it as such with a well-molded cast. You can also look for a fleck avulsion. It's the same as old cast, and look for associated fractures of the tarsal bones. And the management, like I said, the minimally displaced ones we manage in the cast, and then closed reduction with or without K-wires, and rarely, if ever, would you do a RF using screws. So K-wires are usually adequate for children. And having now reached the foot, we have now reached the end of the lower limb fractures in children. Is there any questions from the panel?